Good evening. My name is Brian Devitt. It's a great pleasure to be able to speak to you today on two passions of mine. One is skiing, and the other is orthopedic injuries related to skiing. So, the title of my presentation today is Don't Let Your Knees and Hips Go Downhill, Management of Ski Related Injuries. So, I'm going to start this presentation off with a video, a little bit of a gory video. So, those who have any sensibilities, you may wish to look away now. So, this is a man skiing. And that snap is not his ski binding releasing, but his ACL tearing. And you'll see it in slow motion now. He's a good skier, skiing in deep snow, but you see he's leaning back as he goes into the turn. And that's when his knee is in a vulnerable position, his right knee. And you can hear the maniacal laugh of his friends. So if you friends like those, who need enemies? But I'm sure he did get him off the mountain to a good orthopedic surgeon. So I was privileged enough to do one of my fellowships in Vail, Colorado. And while there, I worked with this gentleman called Dick Stedman. And he used to look out for the US ski team. And he had this phrase that if you were to design a device to rupture an ACL, you couldn't get much better than a ski. And I'll tell you the reasons for that as we go ahead. Well, working in a ski resort is like a conveyor belt of injuries because it's a higher enough risk sport, and a lot of them occur around the knee. It's become hugely popular within society going away on an annual ski trip, and oftentimes there's alcohol included in these trips, so it does make it equally hazardous. So it's a great fun sport, but risky. And if you look at this little cartoon here, we see that knee injuries are way more common related to skiing, but shoulder injuries are more common with snowboarding. So I'm sure Miss Delaney is going to speak to you about shoulder injuries, and she'll be able to show you examples of those. But why is it so risky? Well, it relates to the equipment. So if you're careering down a hill on these two planks of wood with the poles in your hand, there is a large element of risk associated with it. In the past, they used to have boots that went up to the mid shin and were fixed to the ski. They were lashed onto the ski with leather. And nowadays, the instrument's a bit the equipment's a bit different. So initially, the injuries used to occur around the tibia where you'd have fractures or ankle fractures, but now they typically occur more around the knee. And the reason for this is that the boots that we use are incorporate your ankle and go right up to the top of your shin. So where rotation can occur is at the ski itself, but when the boot doesn't release from the binding or the ski, the rotation typically occurs around the knee, hence making it quite vulnerable. The bindings are very important, and these are set by the person who's putting your skis together when you either buy them or more commonly when you rent them. And the reason they ask you your level of expertise is so they can determine how easily or more difficultly your ski boot comes out of the binding. So that's referred to as the din. So if you're anyway suspicious or conscious of your knees, ask the person to set your din at a low rating so your ski boot comes out a little bit easier. And then it's the ski itself. So the skis have changed a lot since they were initially created, and now they're very easy. They're actually conform to how beginner skis as well. So it makes it a lot easier to actually ski compared to what I would have started out on in the 1980s. It also has a relevance in terms of the terrain and conditions. So we saw in the video at the start, there was very deep snow, and that is makes people lean backwards, so you're more likely to lose control when you're turning. But also in conditions like this, where you've very little snow and there's exposed rock, and it's very common for the injuries to happen towards the end of the day when the snow is a bit slushy on the less difficult slopes where people are kind of relaxed, but there's lots of traffic. So a lot of the injuries occur at the end of the day on blue slopes or green slopes, which are regarded as being easy. So how do injuries occur? So we saw a fast video of how they occur at the start, but essentially it's when people lose their balance. And when this example of images here shows when the skier is leaning backwards, when their upper body is rotated into the mountain and one of the knees gets hyperflexed, and then the ski acts as a lever. So they say if you have a lever long enough, you can move the world, but a lever twisting on a fixed knee can tear an ACL pretty quickly. So this is how the injury occurs.
Drop.
It also occurs as a result of stupidity. So sorry about the volume here, but you just can't legislate for people like that. So these people are going to injure themselves no matter where they are in the world or what pursuit they're doing. So what do we do when someone gets injured? Well, on the mountain, you really need to look for help and get off the mountain. But before you get on the mountain, the first thing we recognize in medicine is primum non nocere, first do no harm. So you really need to be conscious of where you're putting yourself on the mountain so you don't cause harm to yourself. And it's also key that you don't chase after that person who's an expert skier if you're only a beginner. And you need to be well aware of where you're going to before you get yourself in harm's way. Skiing is hazardous, but it's hazardous at the end of the mountain as well. And it's not so much that as you as an individual need to look out for yourself, but you have to look out for other lunatics on the mountain as well. And typically, this person was trying to get a drink pretty quickly, but if you get in their way, you're in awful trouble. So you do need to look out for yourself and for others around you. And it tends to return to your comfort zone, particularly when you're going skiing. I would advise that for the first run or two, that you don't go start doing a double black diamond or a black run if you're inexperienced, that you start off on an easy slope, get your ski legs, as we used to call it in our family, and get confident and stay in your comfort zone when you begin. Now you can go outside your comfort zone as the week progresses, but certainly it's advisable to start easily. So what do we do when someone has an injury? So typically, if it happens on the mountain that you're taken off the mountain by an expert, some people can ski down the mountain. But the classic injury we hear about is someone who their ski binding doesn't release. They hear or feel a snap. They fall to the ground. They have difficulty skiing on, and then when they get there, they go down to the clinic at the bottom of the mountain or the medical center. They get an X-ray and they get put into a very overpriced brace, and they're told to either get an MRI straight away or they're told to attend a doctor when they return home. In some cases, people are more um, avaricious and they try to encourage you to have surgery on the mountain. I would certainly advise against that because I think it's important that you make the diagnosis first and then we decide upon what treatment is appropriate and have the appropriate resources around you. But what do we do in the clinic? Well, first of all, we take a good history. And I refer to this editorial, and this was written back in the 1960s by a guy called Professor Apley, and it's still as relevant today as it was when it was written. But one of the nice quotes from this editorial is, "To listen is to learn. We all pay lip service to a careful history, but how many of us are patient enough to elicit one?" So I will say that in terms of taking a history, it's really important that you understand the mechanism of injury, whether the person has any previous knee injuries, and very much you can make the diagnosis by history alone. We then talk about clinical examination, and one of the other great quotes is from this editorial is, "To look at one knee is absurd. Man is biped, and how considerate of nature to provide a normal for comparison. But nature did not provide trousers, and these must be removed." So it's really important when people are making assessments on the side of the mountain. People are generally wearing ski boots, they're wearing salopettes, and it's really difficult to do a proper examination with those paraphernalia on. So when we get to the clinic, we get the person to expose appropriately, and you can very much see the damage. And you see in this example here of a very swollen knee on the right side, and a previous injury to the knee on the left side, which is interesting. So in terms of further investigation, so clinical assessment, we do an anatomical assessment of all the ligaments around the knee and we assess for laxity. And we can typically determine how severe the injury is based on that. But we do like to get some further investigations. So a lot of the time, patients will come with an X-ray, which they got in the clinic. The X-ray can be quite helpful. And we see in this view that there's a tiny little fragment of bone just on the outside of the knee, and that's indicative of an ACL injury. And it will certainly tell you if there's any major fracture. But for the most part, X-rays are they're more rule out fractures than actually make a clear diagnosis. So what else can they do? At the clinics, they often can get an ultrasound. That's not that useful for us in that, yes, you can, it's very much the ability to understand the ultrasound is in the hands of the person doing it, but it's not as transferable to other people who are looking at that scan. So it's not extremely useful for us. But the gold standard is for to do an MRI scan. And this image here, we can see the presence of bone bruising on the outside of the knee and at the back of the knee, which is indicative of an ACL injury. So we use MRI as a very helpful diagnostic tool. And then the next part is referral. So referral appropriately to either an orthopedic surgeon who's looking after these injuries. But it's important that we get the diagnosis and we're able to then move forward with any management appropriately. But to manage these patients, we do it in the cold light of day. So as I alluded to, anyone who's pushing you to have intervention on a mountain, unless it's life-threatening, you're probably better off just being transferred back to your home country where things are available and we can look after you very well in that scenario. So the key for us is to make early diagnosis, so get the diagnosis right. But often treatment is delayed, and it's delayed when the knee is ready for surgery. To go ahead with urgent surgery when the knee doesn't move often results in poor outcomes. So we try to avoid this as best as we can. We often would go down non-operative routes, and I'll give you an example in the cases below, if they're considered appropriate, and sometimes we require operative intervention. One of the things I like to do as part of the assessment is to assess the person's good side. So you look at their normal alignment and assess whether they require a brace. A lot of times people are put in braces unnecessarily. Now, it does give you a little bit of support when your knee is swollen, but I try to remove braces as soon as possible to get the knee moving, to get it ready for rehabilitation or surgery, whichever is necessary. The range of motion, as I said, is critical. So you don't operate on a knee that doesn't move because it's going to result in a knee that's very difficult to move afterwards. So that's really important in terms of early management. I try to get people walking as quickly as I can as well. And to normalize one's gait is to get the muscles working appropriately. And that's very effective in terms of improving their rehabilitation afterwards. So I'm going to give you a couple of examples of cases I've probably seen within the last week or so as to what we frequently see following ski injuries and during the ski season. So the first case we see today is a novice snowboarder. So the typical letter I'll get is, "Thank you for seeing Ben, who had a snowboarding injury 1 week ago, unclear of the mechanism, which is very common. He had swelling early doors, had difficulty weight bearing. He couldn't fully extend his knee, and that results from swelling. He did have an effusion is the phrase we use for swelling in our parlance. And he's currently in a brace, and I've advised him not to weight bear. So thank you for assistance and further management." So part of the history, I have took further history, contact injury turning. So he did strike someone or was struck by someone. He didn't feel or hear a pop, which is important. He fell to the ground, difficulty weight bearing, had to be taken off the hill. It was a high speed contact. No immediate swelling, but did get swollen a little bit later. And then on examination, his knee was flexed. So when your knee is flexed, typically it means there's fluid within the knee. He had difficulty walking. He had an antalgic gait, so it's like a limp. He had a swelling in his knee, and he lacked an ability to fully extend his knee, but there was no block there, so I was able to do it passively. And then he had some laxity of what we call a little bit of opening of the inside of his knee. So in his situation, these are x-rays of his knee. So one of the things we see on these x-rays is that he's a young man and his growth plates are still open. So he's a adolescent individual or pre-adolescent. So he's still a lot of growth remaining. And this often bodes well for people's recovery, but it's important that we respect that this is a growing child. So there's no obvious evidence of any fractures in these x-rays. The x-rays we do are from the front and from the side. We then get an MRI scan, which is more helpful. So an MRI, anything that shows up as white indicates fluid. And we see on the inside of his knee here that he's sprained his medial collateral ligament, or what people will know as an MCL. So he sprained his MCL. This is a view from the inside of his knee, and we see that his ACL is intact. So any person who comes off the mountain with a swollen knee, in my mind, has an ACL injury until proven otherwise. So thankfully for this young man, he didn't injure his ACL and he had an MCL injury. So in his situation, that he was placed in a brace for a few weeks and was allowed full weight bear, and he got his range of motion going, and he's back playing Gaelic within 3 months following his injury without any long-term sequelae. So the next case example is a little bit more serious. So I've coined this legs akimbo. So it was a 42-year-old female, a recreational skier, and she had an unsure mechanism injury as usual. So she was skiing down a mountain, trying to look after her children, and she lost concentration and she slipped with her skis going one each way. She told me that the bindings didn't release. She felt or she heard a tearing sensation within the middle of her knee, and she had great difficulty skiing on. She tried to weight bear afterwards, but needed to be taken off the mountain. And she had immediate swelling in her knee and a really sense of gross instability that she couldn't put any weight through this leg. It felt like it was going to give way. So in terms of her clinical findings, then when I saw her in the clinic, so this was probably 5 to 7 days later, she had great difficulty standing unassisted. She had gross swelling of her knee. So the level of swelling typically indicates the level of injury to the knee, because it means the level of bruising. And she had large amount of laxity or very much a loose knee, particularly on the inside. And we do this test called the Lachman test, which assesses for the stability of the ACL. And she gross instability or increased laxity of her ACL on examination. And most importantly, she had a lot of bruising on the inside of her knee, which would indicate damage to those structures. So I'm going to show you just an example of what we look at with an MRI. So this example here, we've seen the still image, but I'm going to show you this MRI here where we look at the knee from the side. So at the front of the knee, we have the kneecap, the top of the knee, we have the femur, and the bottom, we have the tibia. So I'll go through it now a bit more slowly. So what we're looking for here is the presence of fluid, which shows up as white. We then see that she's an injury to her lateral meniscus. She's got some bone bruising at the back of her knee, and in the middle of her knee, unfortunately, her ACL is torn. And as we go towards the inside of the knee, you see this black structure. The back is her PCL, and the medial side of her knee or inside of her knee, from the meniscus perspective, looks normal, but not from the ligament perspective. So over on the right side, then we see there's a lot of whiteness over the inside of her knee. And we see here on the inside that she's torn her medial collateral ligament. So it's completely torn through its substance. So she had a serious injury to her medial collateral ligament in addition to her ACL with a tear to her lateral meniscus. So I'm just going to show you a couple of examples, and those of you who are a bit squeamish, this is looking inside this person's knee with consent that we could show these images. And what we see here is just the inside of the knee, and we see that this is the meniscus on the inside, but there's lots of space here between the femur and the tibia. So it means that this side of the joint is opening up. So we see this is the ACL that is torn in the front here, this orangey structure here. So we need to reconstruct that. And then we also see on the outside of the knee, this is the ACL again, that she has a little bit of a tear at the back of her lateral meniscus, as we saw on the scan. So we clear everything out, we repair the meniscus, and then what we do is we put back in an ACL in her situation to reconstruct her torn ACL. I'll show you that in just one moment. This is just assessing her knee. And this is the ACL, which we hold in with a screw there. So she did very well following her surgery. So she was placed in a brace. This is her post-operative x-ray. And we got her moving gradually with time with a brace for 6 weeks. And she got back to all her normal activities. So I'm going to start with go on a different tangent with the next case. This is case 3. So this gentleman was affectionately known as Bandy Legs, not by me, by the way, but by his family. He's a 62-year-old male, fanatical skier, as he describes himself. I just imagine that this is what he looks like on the slopes. And his mechanism of injury was quite innocuous, that he was injured his knee while getting out of his boots. So you often experience this. It's probably the best part of skiing is taking your boots off at the end of the day. Well, it wasn't the case for him because his bindings were stiff. He had difficulty twisting, getting into his boots after this, and had a lot of pain over the inside of his knee. He did have swelling. Now, this didn't deter him. He was able to ski after a few winds, but presented with quite a bit of discomfort in this region. So anyone who comes to my clinic who's over the age of 45 will get an x-ray because we want to outrule what is common. And common things are common. And in this situation, arthritis is common at this age. So this is his left knee here. And we see an x-ray, which is performed initially. So on the right side, you'll see that there's nice space between the femur on the top and the tibia below on both sides of the joint. But on the left side, the inside of the joint is quite worn. So he is not just a meniscal tear, but he has arthritis. So he's severe arthritis of the inside of his knee. So in this situation, the treatment for him is not to stick a camera in to take away some meniscus, but ultimately he's looking at a partial knee replacement. So with counsel, we talked about what the surgery entailed, and his symptoms really have been going on a lot longer than his ski accident, and they've been more chronic, and he'd been suffering for quite a while. So we went ahead and we did a unicompartmental or partial knee replacement on this man here. So you see this on this view, you can see the inside of the knee is resurfaced with a partial knee replacement. So the next question he asked is, when can I go back skiing? So in his situation, I had no problem with him skiing. He's functioning very well. He had no pain, no swelling after 3 months. So he went back the following season. So he took probably anywhere between 9 to 12 months to return, but he was able to ski without any problems. And it turns out he wasn't wearing that outfit, because he sent me a picture on the slopes. So it's very possible to get back to the likes of skiing after a partial knee replacement or a total knee replacement, but it really depends on your level of general fitness at the time. And this is a view of the knee from the side. So in terms of the final case, then I'm just going to show another case of a gentleman who really wanted to get back skiing because he missed it. He said it was the best family holiday ever, and the only time his kids wanted to spend time with him, which was interesting. But he's probably right. But he was getting progressive hip pain, so once again struggling even getting his shoes and socks on, but certainly couldn't get his ski boots on without a lot of assistance. He was complaining of a lot of pain at night. On his previous ski trip, he really found it difficult going up the inclines, and he was waddling and wasn't very happy on the ski trip. So we assessed him and we carried out some x-rays. So he had formerly been quite a good rugby player and had a lot of injury to his hips throughout his rugby career. But you see on this x-ray, he's got gross arthritis affecting not just his right hip, but also his left hip. So he's very keen to get back to skiing, and asked, he didn't know what he could do after what was necessary for him, which was a hip replacement. But we did both of his hip replacements at the same time. I did them through an anterior approach, the front of the hip, which in my mind allows slightly easier recovery earlier, but ultimately has the same result as the alternate, which is the posterior approach. But he was very keen to get back to skiing and his activities, and I had no problem with him doing so once he'd recuperated fully. So this is the final results for him. So that brings us to the end of some case examples. I hope you all stay safe on the slopes, and should you have any issues in the cold light of day, don't hesitate to contact us. So thank you very much.
Brian, thanks for a really interesting talk. There's two questions that kind of tie in together, so we'll start with that one. So someone's asking if they're abroad and they get injured and they're being offered surgery, is there someone they can call or contact? Now, there is the info line here. We can type that up for people later. And they're also then asking, is it more advantageous to get the surgery sooner or later? So they kind of tie into one.
Yeah, so there certainly are people, as you said, the information line is very helpful, and when they contact us here, we'll certainly put them in touch with the appropriate individual, whether that be someone who's a specialist in knee, shoulder, foot and ankle, whatever. I think that's a really good resource to have, that you can just ask the question and they'll be able to give you a heads up as to what to do. In most situations, unless it's a life or limb scenario, there's no absolute urgency to have surgery. And I think that's really important, in that, as I mentioned, in the cold light of day is the best time to make these decisions. So whether a definitive diagnosis can be made in the resort, or whether they need to go to a local town to have an MRI, that's one thing. But we can certainly arrange for MRIs very swiftly when people return, and then give them early consultations. Most people in this area have, consultations for acute injury like this. So we can certainly sort all of that out very easily.
Okay, thank you. Here's a question for Barry. Are short ski blades better, less of a risk than regular length skis for leisure skating?
Yeah, well, I suppose it comes down to the length of the ski will determine the lever arm of the ski. So that the torque that is you get from a smaller ski is not as large. So one thing I would say is the bindings can differ. So that if you have shorter skis, sometimes they're fixed bindings. You can't actually, your boot doesn't come out. So it depends on how long they are. So typically people who use the short blades are fairly advanced skiers, and they go over kind of short, like mogul runs and short kind of jumps. So they're probably putting themselves in harm's way a little bit more. But in general, the shorter skis are probably a little bit safer, but you'd have to be an experienced person to use them.
Okay. Are DonJoy knee braces a good way to reduce risk for skiing? Query, got a history of 2 ACLs.
Yeah, so if you look through the literature, that they've looked at a number of different sports and the use of braces to reduce the risk of ACL injury. And it's only in skiing that they've ever shown an advantage to using a brace when skiing. Now, I will qualify that by saying the numbers were pretty small. And in what we've looked at in further biomechanical studies is that these braces only really control the movement, the side to side movement, so that they protect the collateral ligaments, the inside ligament and the outside ligament, but they're not great at controlling rotation. So I would say that they may be somewhat protective, but they're not going to be completely protective of sustaining a further ACL injury.
Okay. So great talk. After partial knee replacement, can you return to skiing, and what can be done to help with this?
Yeah, so as I mentioned at the end of my talk, that you certainly can return to skiing. I think Lindsay Vaughan is a elite level skier, and she had a partial knee replacement and has returned to the ski circuit. So it's certainly possible. I think that one of the things that we always tell people is you need to have good level of general fitness if you're returning following a joint replacement, and really you need to give yourself some time to be able to get over that fitness, and you need to have a knee that's not angry or not going to be vulnerable when you ski. So definitely possible. Time period, it varies between individuals. Typically, I'd say at the very least, I'd say around 6 months to ensure that you're able to do a good level of activity before you get back.
Okay,
Fiona, I didn't answer one of the first part of the question. That was the question regarding when's the most opportune time to have surgery if you have had an injury. And in reality, that it depends on the state of your knee. So if a knee is very swollen and angry, then it's not appropriate to have surgery. That we really would look for a knee that's moving nicely, that doesn't have much swelling, and there's proper activation of the muscles around it. That's the most appropriate time. And that can take up to 6 weeks on occasion, sometimes longer, to be ready. Other knees can be ready much quicker.
Okay, good. There's another question here about ACL, actually. So let me just get that. Is there any definitive test to determine readiness to ski post-ACL reconstruction? Great talk. Thank you.
Yeah, so there are a number of tests that we do, and through the sports medicine department, we subject most of my patients will go through post-operative testing. So a lot of these revolve around assessing the strength of both the quadriceps and the hamstring muscles. We do some jump tests to look at how the individual's behaving when they land on the leg, when they jump off the leg, and we do change of direction tests. Now, these are not specific to skiing, but in general, if someone has good balance and they're allowed to take impact on the leg without any major issue, then that determines that they're reasonably ready. We also use that kind of time period that typically, it's anywhere between kind of 9 to 12 months after injury that you're pretty much ready to go back, but you should really have a kind of sign-off assessment from your surgeon or physiotherapist or rehabilitation specialist before you go back.
Okay, thank you. What is the best way to diagnose a knee injury swiftly? Do you deal with emergencies?
Yeah, so the best way, as I mentioned, is taking a proper history and just really ascertaining what the problem is. Now, that doesn't need to be with a surgeon or a specialist. That your GP or a healthcare professional can be able to look at that history. I think then the diagnosis comes down to clinical examination and the radiological investigations. And they can be organized locally, but we can also organize them for people if they need an appointment. It's a very vulnerable time when someone gets injured abroad, and as I said at the start, we're very happy to help out and very well able to take over that problem. So just contact us and we'll take all the hassle and make it easy for people when they're in that vulnerable state.
It's probably more acute fractures we probably wouldn't deal with. That's the thing. But
and that's the type of stuff that there isn't. We don't have an emergency clinic, but there's certainly even delayed fixation of issues or delayed treatment, cold trauma we refer to it as, it would be well able to manage.
Yeah. And someone's just asking, how would you treat tendonitis in the knee?
Tendonitis can be tricky. It's a situation we typically involve, or most of the time, it's non-operative management. So involve rehabilitation and some particular stretching. We also looked, so occasionally if it's refractory or if it's not settling, with a non-operative management, there are surgical procedures that can be done, but we try to hold off on them until an individual has tried everything else. There can be injection therapies as well. So it can be tricky enough. Tendonitis is not our favorite condition to manage because it's tricky. It can be hard to settle down. It takes some time to settle.
Brian, thanks very much for joining us tonight.